loss in instability. So bone loss in instability spans out the bone loss in the humerus as well as in the glenoid. So I would go through my indications which have changed over a period of time. And so when we started off, as Chirag was saying and other speakers are saying, that we started with like 20%, 25% bone loss, which is considered significant. But over a period of time, we know that with more recent papers that this threshold for conversion to a Latarjet or additional procedures have come down like from 15 to now to 13.5% by paper from Shaha et al. So now, when I looked at my papers, my outcome of in less than 10% Bankart remplissage and rotator interval closure. So we had in a series, it is a short series of around 48 cases, we had just one patient with dislocation. And in my entire series till I've operated till now, I had only 3%, that is 3 patients with recurrent dislocation. So that validates kind of, when you compare to the average statistics, talking about 8 to 28% of failure rate, that validates that possibly what I'm doing is good. So now, when you classify this bone loss, you classify it as less than 10% where you go in for the Bankart remplissage, and in my case, I would do the RA closure less than 30%, 30 years of age group. And then you come to 10 to 15% bone loss, you have multiple options. You have spinoscapular, so you have the dynamic anti-stabilization. So you have the Bankart plus, where you put a small DBM between the capsule and the glenoid. So these are the options in your 10 to 15%. So coming to the spinoscapular, it is a great technique. So I usually, in my indication, it will be between 10 to 15% of bone loss. And so what we do is we take a small piece measuring around 2 centimeters from the spine of the scapula. It should be towards the acromion, just lateral to the spinal glenoid. So here, so you elevate the capsule, and you, in this particular technique, I've used the cortical button Latarjet from Smith & Nephew. So here what we do is, we prepare, then you take the capsule away, bring the jig of the drill, and you can see that coming in, and you drill through, and you can see the sutures being shuttled in, and you can see the spinoscapula there. It will be prepared like that, and then once it is prepared, you just pass it to the joint, and the regular technique of fixation. Next is the dynamic anti-stabilization. We've had excellent results with the DAS. So we developed a technique of dynamic anti-stabilization where Professor Kim had just showed us his technique where he drills. Here what we did was, in this particular technique, we used a ACL jig. That means we used a ACL offset jig, and we drilled 6 millimeter, because we sized the biceps to 6 millimeters. And then we drilled it from anterior to posterior. The average glenoid diameter is going to be like around 24 to 28. So we drilled 6 millimeter to 15, and then shuttled it with a fiber tack tightrope, which flips posteriorly. And it was an excellent technique, and we went to have excellent results. So DAS is an excellent procedure with 10 to 15% bone loss. And sometimes when you have a sudden surprise, so you're doing the Bankart, sometimes the soft tissue is very much insufficient, and you, even after you put up to the 3 o'clock anchor, you suddenly feel that the shoulder is still subluxing. How do you know it's subluxing? When your visualization is through the anterosuperior port, if you can see that the head is still subluxing away, then it is important to have this as backup. So it is a very simple technique. You can fix it in multiple ways, just like how Dr. Kim had shown. You can use a screw, a small 6 mm screw can be used. You can use suture anchors, different techniques of doing it. So this is our technique of doing the dynamic anti-stabilization, where you can see the tightrope being passed in, shuttled, and it will go and flip posteriorly. So this, why we like this particular technique is because one, the screws are not there, there's no solid fixation, and it works on the principle of the ACL healing. So, and then coming to the Latarjet, so my indication for Latarjet would be more than 15% bone loss, and also in primary, even if it is like 10% or 5% bone loss in a contact athlete. So, what about the humerus bone loss? So, Chirag was just mentioning about the glenoid tract. So, glenoid tract, when I looked at the glenoid tract, I felt that it is an arbitrary number. So I felt that there is more to it. How can that, if the patient is, even if you have a tract, so if the patient is going to do a sudden exonotation, sudden jerky exonotation happens. So there is high chance of this dislocating. So we looked at, see this particular thing, how it works. See, even if you do a letargic, sometimes it can still off track. So that means you really need to know you need to do a track when you're doing the letargic as well, to see if it is still dislocating or off tracking. So what we did a 15 patient study. This was this paper was made in 5 years back. I've still not published it. So you can see what happened. Look at the pre-operative tracking of these patients. That is pre-operatively 15 out of 15 were off tracking. What happened to the post-op tracking? You can see 5 were still off tracking even after your letargy. That means the letargy is not insufficient to compensate for your track, at least in 5 out of 15 cases. Then what happens if you add a 5 millimeter extra to this track? So if you add your 5 millimeter, we put this as something called as a borderline track. If you put in 5 millimeter extra, because I did this 5 millimeter was my sudden extra movement. If I did this 5 millimeter extra, see the number of cases. So borderline track is 3. Suddenly you have more number of cases coming into your track. So it means that even if you do a letargy, there is a high chances of at least half of the patient might be still off tracking. So especially when you're doing a Bankart, I think, so this showed me that I should do a remplissage in all my cases. So that's why, irrespective, whenever there's a hillsage, I always do remplissage. Next, coming to distension dislocation. So this is a new concept, and there are 2 papers out there you can see here. That is, if your distance dislocation, when you consider your track, when you saw your track to the edge of the glenoid, if it is less than 8 millimeter, high chance of dislocation. So again, we should always see that track is not a final concept. It is variable, and you should always think about a margin. So if you are, again, this paper says that if your distance dislocation is 8 millimeter, less than 8 millimeter, please do a remplissage. So letargy, so we have had experience with all the systems, LAPO system, the Pascal-Bowley system, Smith and Review, and Arthrex Encerclass system. So I think there is one more talk on that, so I'll not be elaborating. So this is a letargy. So I'm skipping the other Mitex system steps. It is just basically you're showing the subscap split there. And once it is split, you visualize the glenoid surface and bur it and prepare it. And you can see the coracoid fixation. The coracoid is captured, and you fix it onto the anterior glenoid surface. So this is the Mitex system. We have had excellent results. We published the paper on the outcomes of this particular system. Great results, and we had excellent outcomes. And this is the Pascal-Bowley system. This is our own video. So I'm running a video parallel to Dr. Balu's presentation. So you can see that the same system, the same method, but we are replacing the screw with a cortical pattern letargy system. Again, excellent results. You don't have the complications, because the complication we had, especially with the screw system, was that the vertical split fractures and other fractures. So we never had a fracture or a problem with this, and especially in Indian coracoid, where the size is much smaller, this is an excellent device because you have only one button. So again, is there a small problem with this? Yes, sometimes the coracoid orientation is your problem. So you need to really play around and get it in position. So we can see the coracoid going in. So this is excellent. So you can do this without the screws, so avoids all the complications. So then we have the Arthrex Encerclass system, where again we published this paper, this technique, and you can see this how it is done. So we found that 30% of these cases didn't heal up, so we have given up on the system. We don't use that anymore. So coming to our outcomes of the letargy, so these are the outcomes, 2-year follow-up study. Excellent results with the Mitex system and remplissage and capsular repair. We call it as the quadruple effect, published in JCS International last year, this year, 2025. Coming to the Eden hibernate, indication for Eden hibernate for me is more than 25% bone loss. So here. So again, I use the Eden hybrid. I use the cortical button system. So I basically use two buttons. You can see again the jig coming in. So you measure exactly where you want this graft in place, and then you tunnel it, and there are two holes coming in. One here, one proximal, one distal, and once you shuttle the sutures, two sets of sutures, one would be here proline and nylon for me, and then you prepare the graft, and the graft is shuttled and passed through. You can see the graft sitting in place, and you tighten up with the buttons posteriorly. So these are the different options we have. We're now winding up. So the last options, some of the more options we have, which we normally don't use. So lateral clavicle can compensate up to 20%, 22% of the bone loss, and we don't have any experience with the distal tibial allografts, which we compensate up to around 30%. So in summary, I think we have so much papers out there, and there are so many people who have so many concepts. I think our concept should be derived on our experience and what we see in the literature. So here you can see that I have adapted it. So initially starting from 25%, 20%. Now my cutoff is 15%, more than 15% bone loss, I will do a Latarjet, and I will do a Latarjet even in a primary contact athlete more than respect to the bone loss. Number two, 10 to 15% bone loss, I have multiple options like the DAS, I would do a spinoscapular. So, and lastly, in less than 10% bone loss, my technique works. That means the remplissage, the bank card, and the RA closure works very well. So I would say that there should be a gradual, there's a gradual change in the techniques of which been done. We started from open Latarjet with screws, then came to archspecial Latarjet with screws, then gradually the tapes and the buttons. I feel the buttons are really good, and it prevents, it avoids all the complications of the screws. So that's my take. Thanks so much.
Thank you, Dr. Ayyappan.